Keratoconus is a significant cause of visual impairment due to irregular astigmatism and optical aberrations decreasing vision quality. In this case, a young male with grade 2 keratoconus underwent topography-guided PRK followed by corneal collagen crosslinking in order to decrease the refractive error, improve vision quality and to halt the progression of the disease. The Wavelight EX500 SMR laser will be used, which has a proprietary topography-guided ablation pattern called Contoura. This requires obtaining reliable topography measurements which are then transferred to the laser unit. The surgeon must then evaluate the zero refraction ablation which the machine devises to regularize the corneal topography, but should be taken into account in order to input the final desired correction. This treatment is delivered transepithelially and it only takes 8 seconds and ablates about 56 micron. Now to account for epithelium thickness, a PTK of 45 micron is applied. This treatment takes 17 seconds. The next step varies with laser unit and surgeon experience, but the EX500 tends to induce myopia after a PTK, so this needs to be accounted for in a final treatment of -0.75 diopters, which takes 2 seconds and ablates 12 micron. The laser treatment part of the procedure is now complete. Next, mitomycin 0.02% will be applied during 30 seconds to prevent haze, followed by copious irrigation with BSS. We are now ready to advance to the second part, which will be a same-day sequential corneal cross-linking procedure, using riboflavin 0.1% and UVA light, to harden the corneal stroma, halting keratoconus progression and inducing further Kmax flattening. To begin, the corneal stroma is dried with a cellulose sponge. Then a few drops of riboflavin are applied in the corneal center and repeated each 2 minutes until about 15 minutes. Excess spilling of riboflavin is avoided by drying the limbus and scleral area. Notice that while this is done immediately after a PRK procedure, the patient is relatively cooperative and comfortable during the cross-linking treatment. After 15 minutes of riboflavin saturation, the UVA light device will be placed at a distance of 5 cm from the corneal apex, and is said to deliver a dose of 6 mW per square centimeter, with a spot size of 8 mm. This light energy will be applied during 15 minutes, while riboflavin is also further instilled at about 3 minutes interval. To finalize BSS irrigation, antibiotic and ketorolac drops are applied and a therapeutic contact lens is placed. Now the full combination sequential procedure of topoguided PRK and cross-linking is complete. The post-operative period is similar to a conventional PRK with some discomfort in first 5 days, and then progressive improvement in visual acuity, and a very noticeable improvement in corneal topography and high-order aberrations.